Enhancing your critical thinking, real-life nursing scenarios. Hey everyone, and welcome to our educational series, a space specifically designed to sharpen those critical thinking skills that are so vital for you as a nursing student. I'm Darlene Jackson, and I'm thrilled to guide you through today's session. We're not just going to talk about theories, we're going to immerse ourselves in practical, real-world situations that you'll likely encounter in your nursing career. This is all about bridging the gap between textbook knowledge and on-the-floor decision-making, helping you to think like a seasoned nurse even before you graduate. Today, we're diving deep into 5 vivid patient scenarios. Each one is carefully crafted to challenge your understanding of pathophysiology. That's the why behind diseases and, crucially, patient care. These aren't just case studies. They're opportunities for you to step into the shoes of a practicing nurse, to analyze symptoms, to consider underlying conditions, and to prioritize interventions. We'll explore different age groups, varied complaints, and complex medical histories, all designed to make you think critically and act decisively. This is your chance to test your knowledge and build your confidence. So grab your notebooks, put on your thinking caps, and let's really get into the nitty-gritty of what makes nursing such a challenging yet rewarding profession. We're going to dissect each case, discuss the science, and highlight the essential nursing actions that can make all the difference in patient outcomes. This is about learning actively, not passively. Are you ready to push your understanding and prepare for the realities of patient care? Fantastic! Let's get started. The breathless patient understanding heart failure and pulmonary edema. Our first patient is Mr. Henderson, a 65-year-old male who presents to the emergency department with acute shortness of breath. He reports feeling like he's drowning, especially when he tries to lie flat, and mentions that his ankles have been increasingly swollen over the past week. Now, when we hear shortness of breath and swollen ankles in an older adult, our minds should immediately start thinking about the heart. Specifically, we're considering heart failure. Pathophysiologically, heart failure means the heart muscle isn't pumping blood as effectively as it should. Think of it as a pump that's losing its power. This can be due to various reasons like long-standing hypertension, a previous heart attack, or valve problems. When the left ventricle, the main pumping chamber, weakens, it can't eject all the blood it receives from the lungs. This causes a backup of pressure into the pulmonary veins and capillaries. This backup is critical because it directly leads to pulmonary edema, which is essentially fluid accumulation in the alveoli, the tiny air sacs in the lungs. Imagine those air sacs, normally clear for gas exchange, becoming waterlogged. This is why Mr. Henderson feels like he's drowning. His lungs are literally filling with fluid, making it incredibly difficult to breathe and exchange oxygen for carbon dioxide. The orthopnea, his difficulty breathing when lying flat, occurs because gravity allows more fluid to pool in the lungs when he's supine. The swollen ankles or peripheral edema often point to right-sided heart failure, which can occur alongside left-sided failure or on its own, where the right ventricle struggles to pump blood to the lungs, causing a backup in the systemic venous system. So, what are our priority nursing interventions for Mr. Henderson? First, think ABCs: airway, breathing, circulation. We need to ensure his airway is patent and improve his oxygenation. This means administering high-flow oxygen, possibly via a non-rebreather mask, or even non-invasive positive pressure ventilation, like CPAP, if he's in severe distress. We'll want to place him in a high Fowler's position, sitting upright, to help reduce venous return to the heart and allow for better lung expansion. Establishing IV access quickly is crucial for administering medications like diuretics. Furosemide is a common one, which will help his body excrete the excess fluid. We'll also monitor his vital signs closely, especially oxygen saturation, respiratory rate, and blood pressure. An EKG, chest X-ray, and cardiac enzymes will also be key diagnostics. The agonizing abdomen, navigating acute appendicitis. Next, let's consider Miss Chen, a 45-year-old female who arrives at the clinic complaining of severe abdominal pain. She states the pain started vaguely around her umbilicus about 12 hours ago, but has now migrated to her right lower quadrant and has become sharp and constant. She also reports nausea and a low-grade fever. These classic symptoms, periumbilical pain migrating to McBurney's point, nausea, fever, and often anorexia, should set off alarm bells for acute appendicitis. The appendix is a small, finger-like pouch attached to the large intestine. Appendicitis occurs when this pouch becomes inflamed, usually due to an obstruction, often by a fecalith, a hard piece of stool, lymphoid hyperplasia, or even a tumor, though less common. This obstruction traps bacteria, leading to infection, inflammation, and increased intraluminal pressure within the appendix. If this inflammation and pressure aren't relieved, the appendix can become ischemic, then necrotic, and eventually, it can rupture or perforate. This is a serious complication because it spills bacteria and inflammatory contents into the peritoneal cavity, leading to peritonitis, a widespread and potentially life-threatening infection of the abdominal lining. That's why timely surgical intervention and appendectomy, removal of the appendix, is so critical. We can't afford to wait and see if it gets better on its own, because the risk of rupture increases significantly with time, usually within 24 to 72 hours of symptom onset. Early diagnosis and surgery are key to preventing these severe complications and ensuring a smoother recovery for Ms. Chen. So what's our role as nurses in her preoperative and postoperative care? Preoperatively, once appendicitis is suspected, Ms. Chen will likely be made NPO, nothing by mouth, in anticipation of surgery. We'll need to establish IV access for fluids to maintain hydration and for antibiotic administration, which is often started prophylactically. Pain management is important, but we need to be cautious with strong analgesics that might mask worsening symptoms before a definitive diagnosis is made by the surgical team. We'll also be preparing her for surgery, which includes ensuring informed consent is obtained, completing preoperative checklists, and providing emotional support. Postoperatively, our care will focus on monitoring her vital signs, assessing her pain levels, and providing analgesia, checking the surgical incision for signs of infection, redness, swelling, discharge, and encouraging early ambulation to prevent complications like blood clots and atelectasis. We'll also monitor for the return of bowel function and gradually advance her diet as tolerated. Chapter 3. The Blinding Headache, Unmasking a Brain Aneurysm. Let's shift gears to a neurological emergency. Our third patient is Mr. Davies, a 30-year-old male who is brought in by ambulance after experiencing a sudden, excruciating headache, which he describes as the worst headache of my life. He also reports some neck stiffness and photophobia, or sensitivity to light. This classic description, particularly the worst headache of life or thunderclap headache, is highly suggestive of a subarachnoid hemorrhage, most commonly caused by a ruptured brain aneurysm. A brain aneurysm is a weak, bulging spot on the wall of an artery in the brain. Think of it like a weak spot on an old tire that bulges out and can eventually burst. These can be congenital or develop over time due to factors like hypertension, smoking, or certain genetic conditions. When it ruptures, blood spills into the subarachnoid space, the area between the brain and the thin tissues that cover it. This bleeding is a critical event because it increases intracranial pressure, irritates the meninges, causing neck stiffness and photophobia, and can directly damage brain cells. The potential complications following a ruptured aneurysm are severe and numerous. Rebleeding is a major concern, especially in the first 24 hours, and carries a high mortality rate. Cerebral vasospasm, a narrowing of the brain's blood vessels, can occur several days after the initial bleed, leading to ischemic stroke and further neurological deficits. Hydrocephalus, an accumulation of cerebrospinal fluid causing increased intracranial pressure, can also develop. Seizures are another risk. Therefore, rapid diagnosis through CT scan, possibly followed by a lumbar puncture if the CT is negative, but suspicion remains high, and cerebral angiography to locate the aneurysm is paramount. As nurses, our assessments and interventions are crucial in managing Mr. Davies. Key nursing assessments include frequent and detailed neurological checks, Glasgow Coma Scale, pupillary response, motor strength, and sensory function. We must monitor his vital signs vigilantly, paying close attention to blood pressure, as hypertension can increase the risk of rebleeding, while hypotension can worsen ischemia if vasospasm is present. We need to assess for signs of meningeal irritation, like nuchal rigidity or Kernig's and Brudzinski's signs. Interventions will focus on maintaining a calm, quiet, and dimly lit environment to minimize stimulation. The head of the bed is typically elevated to 30 degrees to promote venous drainage and help lower intracranial pressure. Seizure precautions should be implemented. We'll administer prescribed medications, which may include nimodipine to prevent vasospasm, analgesics for pain, antiemetics for nausea, stool softeners to prevent straining, and possibly antihypertensives or anticonvulsants. We also play a vital role in preparing him for potential neurosurgical or endovascular procedures to secure the aneurysm. Chapter 4. The confused elder decoding hyponatremia and cerebral edema. Our fourth scenario involves Mrs. Rodriguez, a 70-year-old female whose family brought her to the clinic because she's been increasingly confused and weak over the past few days. She has a history of hypertension and is on a diuretic. Upon assessment, she appears lethargic and is disoriented to time and place. Given her age, diuretic use, and neurological symptoms, we need to consider electrolyte imbalances, particularly hyponatremia, a low sodium level in the blood, typically defined as less than 135 mcl. There are many potential causes of hyponatremia in older adults, including the use of thiazide diuretics, which can increase sodium excretion, syndrome of inappropriate antidiuretic hormone secretion, excessive water intake, heart failure, kidney disease, or even adrenal insufficiency. The effects of hyponatremia are primarily neurological because sodium is a key electrolyte in maintaining fluid balance and nerve function. When blood sodium levels drop, it creates an osmotic imbalance. Water moves from the area of lower solute concentration, the blood, into the area of higher solute concentration, inside the cells, causing cells to swell. This is particularly dangerous in the brain because the skull is a rigid container, leaving no room for expansion. So, brain cells swell, leading to cerebral edema. This increased intracranial pressure and cellular dysfunction manifest as confusion, lethargy, headache, nausea, muscle weakness, and in severe cases, seizures, coma, and even death. The severity of symptoms often correlates with how low the sodium level is and how quickly it has fallen. For Mrs. Rodriguez, our critical nursing actions will revolve around careful correction of her sodium levels and managing her symptoms. First, we need to confirm hyponatremia with lab tests and investigate the underlying cause. Treatment depends on the cause, severity, and whether it's acute or chronic. If it's related to her diuretic, it might be stopped or changed. If she has fluid overload hyponatremia, fluid restriction might be implemented. In cases of severe symptomatic hyponatremia, administration of hypertonic saline, for example, 3% sodium chloride may be necessary, but this must be done very cautiously and slowly. Rapid correction of chronic hyponatremia can lead to a devastating condition called osmotic demyelination syndrome, formerly central pontine myelinolysis. We must perform frequent neurological assessments, monitor her serum sodium levels closely, maintain strict intake and output records, and implement safety precautions due to her confusion and weakness, such as fall precautions and possibly seizure precautions if her sodium is critically low. Chapter 5. The crushing chest pain, responding to myocardial infarction. Our final patient is Mr. Miller, a 50-year-old male who calls emergency services complaining of sudden, severe, crushing chest pain that radiates to his left arm and jaw. He also reports feeling nauseous, sweaty, and short of breath. These are hallmark symptoms of an acute myocardial infarction, commonly known as a heart attack. An MI occurs when blood flow to a part of the heart muscle is acutely blocked, usually by a thrombus or blood clot that forms on a ruptured atherosclerotic plaque in a coronary artery. This blockage deprives the heart muscle cells, or myocytes, of oxygen and nutrients, leading to ischemia. If blood flow isn't restored quickly, this ischemia progresses to infarction, which is irreversible cell death or necrosis of the heart muscle. One of the key diagnostic markers we look for in a suspected MI is an elevation in cardiac troponin levels. Troponins, specifically troponin 1 and troponin T, are proteins found in heart muscle cells that are released into the bloodstream when there's damage to the heart muscle. Elevated troponin levels are highly specific for myocardial injury and typically begin to rise within a few hours of symptom onset, peak around 12 to 24 hours, and can remain elevated for days to weeks. If Mr. Miller's electrocardiogram shows ST segment elevation, this indicates an ST elevation myocardial infarction, or STEMI. A STEMI usually signifies a complete and persistent blockage of a coronary artery, and it's a true medical emergency requiring immediate reperfusion therapy to restore blood flow and save heart muscle. Time is muscle. The immediate nursing care for a patient like Mr. Miller with a suspected STEMI is critical and follows established protocols. Often, you'll hear the mnemonic Mona, morphine, oxygen, nitroglycerin, aspirin, although the order and specific application can vary. Oxygen is typically administered if oxygen saturation is low. Aspirin, chewable for rapid absorption, is given for its antiplatelet effect. Nitroglycerin, sublingual or spray, is used to dilate coronary arteries and reduce preload, thereby decreasing myocardial oxygen demand. but it's contraindicated in certain situations like right ventricular infarction or recent phosphodiesterase inhibitor use. Morphine can be given for pain relief if nitroglycerin isn't fully effective, and it also has some venodilating properties. Beyond MONA, we need to obtain a 12-lead ECG within 10 minutes of arrival, establish IV access, draw blood for cardiac markers, including troponin, and continuously monitor his cardiac rhythm and vital signs. The primary goal is to prepare him for rapid reperfusion, either through percutaneous coronary intervention or angioplasty with stenting, in a cardiac catheterization lab, ideally within 90 minutes of first medical contact, or with thrombolytic or fibrinolytic therapy if PCI is not readily available. And that brings us to the end of our 5 patient scenarios. Thank you so much for joining us in this educational journey today. I truly hope that walking through these diverse and challenging cases has stimulated your thinking and helped you connect the dots between pathophysiology, patient presentation, and essential nursing interventions. Remember, developing strong critical thinking skills is not a one-time event. It's an ongoing process of learning, questioning, and reflecting on your experiences. These scenarios are just a stepping stone to help you build that solid foundation. We hope these scenarios have genuinely helped you think critically about the complexities of patient care and the intricate details of various disease processes. The goal was to make these conditions come alive, to move them from the pages of your textbooks into a more dynamic, real-world context. Understanding the why behind a patient's symptoms and the rationale for our nursing actions is what elevates us from task doers to true patient advocates and skilled clinicians. Continue to ask questions, seek out knowledge, and challenge yourself to understand at a deeper level. Please stay tuned for more educational content designed to enhance your nursing skills and prepare you for the incredible responsibilities and rewards of this profession. We're committed to providing you with valuable insights and practical knowledge that will serve you well as you progress through your studies and into your career. Keep learning, keep growing, and never lose that passion for patient care. Until next time, take care and study smart.